I have a copy of my lab results from the fall of 2020 sitting in a folder in my kitchen drawer. 22 markers on that printout, every single one of them stamped within normal limits in green. My doctor shook my hand, said, "Good work," and told me he would see me in a year. At least, that is what the report said. What it did not say was that there were 5 markers my doctor had never ordered. Markers that major health institutions say can tell you things about your cardiovascular and metabolic health that a standard blood panel completely misses. I only found out about them because I got scared enough to start reading. I was 65 at the time, and I had just come off a conversation with my cardiologist that I was not prepared for. He had used the word stent in the same sentence as my name. He walked it back quickly, said we were just having the discussion, but I heard what I heard. I sat in the parking lot for 20 minutes before I could drive home. That kind of conversation changes how you pay attention. I started reading every clinic handout and study summary I could get my hands on. NIH fact sheets, American Heart Association guidelines, Cleveland Clinic patient guides. And the more I read, the more I noticed the same tests appearing in the research that I had never seen on any of my own lab panels. When I brought them up with my primary care doctor, he wrote the orders without pushback. He simply had not offered them. There is no money in teaching you to ask for the cheap lab test. The supplement industry would rather sell you something you can order online without you ever knowing whether you actually need it. And a 10-minute office visit has no room for the conversation where you sit down and say, "What is not on this panel that maybe should be for someone my age with my history?" My name is Wayne Ellison. I am 68. I am not a doctor, and nothing I say here is medical advice. This is educational. After my own scare, I started reading the studies myself and talking to my doctor like we had more than 10 minutes. I want to show you exactly what I found and exactly what to bring to your next appointment. 5 blood tests that are not on a standard panel, what each one measures, why it matters after 60, and the name to use when you call to request it. How does a person get to 65 and not know these tests exist? Simple, nobody mentioned them. The standard metabolic panel, the basic lipid panel, the complete blood count. Those are the defaults. If you do not know to ask for something different, you do not get it. And if you do not know what to ask for, the map stays incomplete. The first test I asked for by name changed how I thought about all the others. Test number 1, high-sensitivity C-reactive protein. C-reactive protein, or CRP, is produced by your liver when there is inflammation somewhere in your body. The high-sensitivity version of this test, which the lab labels HSCRP, can detect low-level chronic inflammation that the standard CRP test is not precise enough to catch. A joint scientific statement from the American Heart Association and the Centers for Disease Control recognizes HSCRP as a marker associated with cardiovascular risk. As of 2026, the AHA guidance associates levels below 1.0 milligrams per liter with lower cardiovascular risk, 1.0 to 3.0 with average risk, and above 3.0 milligrams per liter with higher risk. My result came back at 3.8. That is not a typo, by the way. My doctor had not ordered it. I asked for it by name after reading the AHA guidance at home. When I showed him the number at my follow-up, he leaned back in his chair and said it was worth keeping an eye on. That was it. Worth keeping an eye on. Here is the mechanism in plain terms. Long-term, low-grade inflammation is associated with the kind of arterial damage that accumulates quietly over years. The American Heart Association has stated plainly that chronic inflammation plays a role in the development of cardiovascular disease. An HSCRP result above 3.0 gives you and your doctor a concrete signal that warrants a real conversation, even when everything else on your standard panel prints green. With my doctor's guidance, I started walking 20 to 30 minutes most days. The Mayo Clinic associates regular moderate physical activity with reduced CRP levels over time. I cut back hard on processed foods and added more fatty fish, specifically salmon and sardines, which are associated with reduced inflammation through the omega-3 pathway. I had the test rechecked at my next annual, so we had a second data point to work with. This test is worth asking about, especially if you have a family history of heart disease, if you have already had a conversation about cardiovascular risk, or if you simply want a more complete picture of what is happening beyond your cholesterol numbers. Ask your doctor for the high-sensitivity CRP test. Use those exact words. High-sensitivity CRP. If you just say CRP, you may get the standard version, which is less precise for the kind of low-level inflammation we are talking about. If you take blood pressure or cholesterol medication, talk to your doctor before making any other changes. But what you have probably heard about inflammation, that is not the full picture. For a while after I started walking more and watching what I was eating, I thought I had found the main thing I had been missing. That did not last. Test number 2, 25-hydroxy-vitamin D. When you call to request the test, use the full name, the 25-hydroxy-vitamin D test. The reason that specific phrase matters is that there is more than one way to measure vitamin D in the blood, and the 25-hydroxy version is the one that tells you what your body actually has in storage. According to the NIH Office of Dietary Supplements, vitamin D deficiency among older Americans is common, and the risk increases after 65 because skin produces less vitamin D from sun exposure as we age. The NIH dietary reference values set the daily requirement at 600 international units for adults 51 to 70 and 800 for those over 70 as of 2026. At 65, eating the way I had been eating, I was not hitting either of those numbers through food and indoor living alone. The standard lab threshold for deficiency is 20 nanograms per milliliter. My result was 22. Green checkmark, normal. But 22 and 46 are not the same number, even if they get the same green stamp on the same printout. The NIH lists the sufficient range as 20 to 50 nanograms per milliliter. Being at the floor of that range at 65 is a different situation than being in the middle of it, and it is a conversation worth having. Vitamin D is connected to bone density, immune function, and muscle strength, all things that matter more, not less, as we get into our 60s and 70s. The NIH and major clinical institutions have documented these associations extensively. I brought the question to my doctor at my next visit. He agreed it was worth addressing. We discussed modest supplementation and scheduled a follow-up test 6 months out. That conversation would not have happened if I had just looked at the green checkmark and gone home satisfied. I will not suggest a specific dose here. Vitamin D is fat-soluble, meaning excess builds up in your body in a way that water-soluble vitamins do not. Too much is a real concern. Get the 25-hydroxy-vitamin D test first, find out where your number actually sits, and then have the conversation with your own doctor about what makes sense for your specific situation. This test is especially worth requesting if you live in a northern climate, spend most of your time indoors, or have darker skin, all of which reduce how much vitamin D your body produces from sun exposure. This is where the story takes a turn nobody expected. Test number 3, homocysteine. This is the one I wish someone had told me about 10 years earlier. Homocysteine is an amino acid that builds up in your blood as a byproduct of how your body processes certain proteins. A certain amount of it is completely normal. When your levels of B6, folate, and B12 are where they need to be, your body processes homocysteine and clears it without issue. When those vitamin levels fall short, homocysteine accumulates. The American Heart Association has stated that elevated homocysteine is associated with increased cardiovascular risk. That is the heart side. Separately, NIH-funded research has also examined an association between elevated homocysteine and measures of cognitive health in older adults, including the risk for decline over time. 1 blood test. 2 systems that I spend a lot of time thinking about now that I am in my late 60s. My homocysteine came back elevated the first time I had it checked. I had never had it measured before. I was 65 years old. My doctor was honest with me in a way I respected. He said the research on using B vitamin supplementation to bring homocysteine down is not as straightforward as we would like. Clinical trials have not consistently shown that lowering the number reduces heart events. The association between elevated homocysteine and cardiovascular risk is established and recognized. What is less settled is whether the number itself is the driver or whether it is pointing at something else going on beneath the surface. Which, looking back, was exactly the kind of complicated, honest answer I needed, rather than either a wave of the hand or a list of supplements to order online. With my doctor's guidance, I focused on food first: leafy greens and legumes for folate, eggs and poultry for B6, and I had my B12 checked as a separate test because B12 absorption decreases with age and it is further affected by some common medications, including metformin, which a number of people in our age group are already taking. That detail about B12 and metformin was a warning sign hiding in plain sight for a lot of people. Anyone on metformin for more than a couple of years who has not had their B12 specifically checked has a conversation worth having with their doctor. A year or so later, I understood exactly what my elevated homocysteine result actually meant for my situation. It was information I could work with, and it opened a longer conversation about nutrition that I think was long overdue. Your lab can run homocysteine as a simple blood draw, and your doctor can add it to any routine order. If you are over 60 and have never had it checked, that is a straightforward ask at your next appointment. Before I get to the last two tests, if this kind of information is what you come here for, click subscribe and drop your age and the number you are working on in the comments below. I read every one of them. The fourth test is one I had to explain to my own doctor before he wrote the order. Test number 4, fasting insulin. Your doctor almost certainly checks your fasting blood sugar at your annual. Many also run an A1C, which reflects your average blood sugar over the prior 2 to 3 months. What a standard metabolic panel typically does not include is a fasting insulin test. Here is why that matters. The American Diabetes Association recognizes that insulin resistance can be present for years, sometimes many years, before blood sugar rises out of the normal range. Your glucose reads fine. Your A1C reads fine. Your body may already be working significantly harder than it used to just to hold those numbers in place. A fasting insulin test measures how much insulin is circulating in your blood after you have fasted overnight. When that number comes back elevated alongside a still normal blood sugar, it is a signal that your cells have become less responsive to insulin than they should be. The pancreas compensates by producing more. The blood sugar stays controlled for now, but the system is under strain. I asked my doctor to add fasting insulin to my last annual panel. He wrote the order, and then he mentioned, unprompted, that he genuinely did not have many patients who asked for it by name. And no, I am not making that up. My result came back elevated, not dramatically, but enough that my doctor and I had a detailed conversation about what I was eating for breakfast, specifically, what time I was eating it, how much of the meal was refined carbohydrate, and whether I was giving my body any time in the morning before my first bite of the day. And then that conversation led to one decision that changed how my mornings look entirely. I cover the breakfast piece in a separate video, and I will point you directly to it at the end of this one, because it connects to exactly what I just described. If you manage your blood sugar with medication, talk to your doctor before changing what you eat or when you eat it. That is a serious caution, especially if you take insulin or anything in the same class as metformin. Up to this point, the first 4 tests had all pointed at the heart or at metabolism. The 5th one moved into territory I had not expected. Test number 5, ferritin. Ferritin is the protein your body uses to store iron. It is different from the iron circulating in your bloodstream at any given moment, which is what a standard iron test measures. Serum iron tells you what is in transit. Ferritin tells you what is in reserve. You can have a completely normal serum iron reading and still have low ferritin. And when ferritin is low, the Mayo Clinic associates it with fatigue, difficulty concentrating, poor sleep quality, and brain fog. The kind of symptoms that are very easy to attribute to getting older. Symptoms I had been attributing to getting older for 2 or 3 years before I thought to check this particular number. The Mayo Clinic notes that ferritin below 30 nanograms per milliliter can cause these symptoms, even when serum iron reads as normal. Here's the catch. Lab reference ranges for ferritin vary widely between labs. Some set the lower boundary of normal as low as 12 nanograms per milliliter. A result of 15 can print on your lab report without a single flag, while still leaving you tired, foggy, and running out of steam by 2 in the afternoon. So, yeah, not great. My serum iron had always come back normal. My ferritin, when I finally had it specifically checked, was below 30. My doctor ran a complete iron panel to rule out any underlying cause before we changed anything, which is the right sequence. Once we had a fuller picture, we talked through dietary adjustments. Lean red meat a couple of times a week, more leafy greens, more legumes. Foods that bring other benefits to the conversation for different reasons. A few months later, I felt clearer. I offer that as a personal observation only. Your situation is different from mine. What I know is that ferritin is now on my annual list, and I bring the number to my doctor the same way I bring the HSCRP. When you call to schedule your next lab work, ask for ferritin by that exact name. Ferritin. The same way I learned to ask for all 5 of these, by name, on purpose, ahead of time. That folder in my kitchen drawer, the lab printout with 22 green check marks. I still have it. I look at it differently now. Every number on that page was accurate. What it was missing were the 5 questions I had not yet learned to ask. The map was complete for what it covered. It just did not cover enough. The 5 tests I covered today can each be added to a routine blood draw. None is expensive compared to what I used to spend on supplements I no longer take, and none replaces anything your doctor has already prescribed. They are information, and information is the only thing that gives you a real conversation instead of a handshake and a green check mark. Write these down before you close this video. High sensitivity CRP, 25-hydroxyvitamin D, homocysteine, fasting insulin, ferritin. Take that piece of paper to your next appointment and tell your doctor you have been reading about these markers and would like to talk through which ones make sense to add to your panel. Your doctor will either order them or explain why one does not apply to your specific situation. Either answer is more useful than not knowing the question existed. None of this cost me a fortune, and none of it is a miracle. Write down what you want to ask and bring it to your own doctor before you change anything, especially if you take medication. If this helped you, subscribe and tell me in the comments what number you are currently trying to get down. I read them all. And while you are here, if your A1C came back borderline, or if what I said about fasting insulin struck a nerve, I did a video called What I Changed at Breakfast When My A1C Came Back Borderline. It goes directly into what I eat, when I eat it, and what my doctor said about timing. Tap it on the end card right now and keep watching.